Hello, I'm Victoria Bond. Today I'm going to be talking about bariatric patients and special considerations that we need to take in retrieval medicine. Now, I think any topic is more interesting with a case, so we're going to start with a case that I experienced a couple months ago, and it all starts with the backhoe. And essentially it goes a little bit like this. We've got a 47-year-old male. He presented to Leeton Clinic, which is a nurse-only clinic, confused and febrile, presenting with a presumed lower respiratory tract infection and the first presentation of HHS. He also has a concurrent acute renal failure. He appears to be tiring and rapidly progressing to type 1 respiratory failure. His hemodynamics are sagging after a couple liters of fluid, and he is now pressor dependent. And by the way, he's 280 kilograms. Now, if you're anything like me, this is what you would do next. But luckily, I was working with an excellent team. I'm just going to pause here so we can go over what this lecture is actually going to cover. We're going to go through a little bit of special considerations to do with bariatric physiology, most notably dealing with the airway, ventilation, circulation, disability, and drug doses, and of course talking about vascular access and manual handling, which are invariably more complicated in these patients. Now, often we rely on BMIs to look at definitions of overweight, obese, morbidly obese, supramorbidly obese, and while these are useful, in the context of retrieval medicine, we're actually much more interested in the width and height of patients. Ultimately, it's a patient's width and height that's going to determine what your transport options are, differentiating between rotary wing, fixed wing, and multi-purpose vehicles. So we'll begin with our airway considerations. These patients are typically difficult to intubate, and that's for a multitude of reasons. They've got short necks, their neck extension is often quite poor, especially if they have the deposit of fat on the back of their neck, and their chest wall may interfere with laryngoscopy. You may actually need to use a different handle, shortened handle, or an hyperangulated or different blade to what you usually use to actually get a view of the cords in these patients. They're very difficult to pre-oxygenate, and they often experience very rapid desaturations in the process of intubating these patients. It should be noted, however, that perception of difficulty may actually also contribute to the difficulty in intubating these patients. There's significant anxiety around intubation, which may harmfully delay intubation in some patients to the point where they're crashing when you're attempting your first look. And it may also delay extubation. There's been a few studies on morbidly obese patients undergoing elective surgery, which have actually found that BMI or body weight were not actually predictive of difficult intubation. But interestingly, the Mallampati score and neck circumference were prognostic. I think the important thing if you're going to be considering an airway in these patients is to really focus on your positioning. And this is often quite difficult due to the body habitus alone. But often people find that if they position these patients properly, that the airway is not as difficult as anticipated. Now, breathing considerations are significant in your bariatric patients. Increasing BMI is associated with a reduction in respiratory compliance, and this is partly due to the increased weight on the chest wall and restriction of diaphragmatic movement from increased intra-abdominal pressure. These patients often suffer from pulmonary hypertension and have increased pulmonary blood volume for reasons that we'll go through a little bit later. But anyway, this reduction in compliance associated with increased mechanical pressure results in an increased work of breathing and often increases the metabolic demand associated with breathing. So you'll find that these patients desaturate very quickly for a multitude of reasons. Now, giving PEEP to these patients can often help in your FRC, but remember that this will be at the expense of your preload, and in patients who are hemodynamically unstable, you'll need to tread carefully with your PEEP. These patients are almost universally suffering from sleep apnea and CO2 retention, and invariably will have some degree of pulmonary hypertension. If we're going to boil it all down, we can say expiratory reserve volume is decreased, your FEV1 to FVC ratio is increased, your FRC and your compliance are decreased, your work of breathing is increased, and your production of carbon dioxide for all of those reasons is increased. You've got an increased risk of aspiration pneumonia due to your heightened intra-abdominal pressures, and also these patients generally have a higher incidence of gourd and hiatus hernia. All of these things can be mitigated to some degree by managing pre-oxygenating and sometimes intubating these patients relatively sitting up to some degree. Sitting up will help with both compliance and ventilation of West's lung zone 3. I think it's sometimes easy to fall into the trap of considering a bariatric patient as a 70-kilogram person in a 200-kilogram body. But that's not actually true. These patients have an increased muscle mass and an increased circulating blood volume. There's pressure effects of adipose tissue over the thorax and the abdomen, and they also have a completely normal blood-brain barrier. And the combination of these things give us some considerations when dealing with circulation and disability in these patients. In terms of your circulation, I sometimes think it's easy to think of it as everything is a little bit ramped up. So they've got an increased cardiac output, they've got increased metabolic demands, increased oxygen consumption, and an increased total blood volume. They often suffer from some component of left and right ventricular failure or left and right ventricular hypertension. And so it's very, very important in these patients to tread softly when it comes to any interventions that may impact your preload or your afterload, because it's very likely to decompensate a hidden cardiac injury or disease. Now onto disability and drugs. It's important for any clinician using these medications to know what they're dealing with in terms of excretion type, half-life, blood-brain barrier, bioavailability, whether they're lipophilic or hydrophilic, and what their total volume of distribution is. Simply put, when you're dealing with a bariatric patient, you have to remember they have an increased muscle mass and increased circulating blood volumes. So for paralytics, I like to calculate about 150% of the ideal body weight of a patient, understanding that the half-life may be slightly decreased due to their metabolic demand. They've got a normal blood-brain barrier, which means that induction agents will calculate to about 100% ideal body weight, or even less if they're shocked. Their increased adipose stores mean that any medications that we give which are lipophilic tend to have prolonged effects, but that's only really on the long-term infusions. You might also find, paradoxically, that the effects of sedatives wear off quicker due to the increased metabolic demand of these patients. And finally, you need to keep in consideration hepatic and renal clearance, which may both be impaired, particularly in shocked patients. Now, I think the elephant in the room, if you'll pardon the pun, is the vascular access in these patients. We're dealing with invariably more difficult access issues. Physical landmarks are lost, pulses can be difficult to palpate, the skin to blood distance is greater, and typically the vessel sustains more punctures in these patients, and they suffer from a greater risk of thrombosis. I think it's important for these patients to get definitive access, to get it early, and to get access which will allow you to give all of the medications in the volumes required. Essentially, this means choosing to go for central venous access and ultrasound-guided arterial lines early. Now we're going to move back to our case. While I was thinking all of these things over and panicking just a little bit, I found out that the Orange team had already been sent out to this patient during the day. I was rostered on a night shift. So essentially, the patient was now intubated, ventilated, sedated, and had a central line in situ. The clinic unfortunately had run out of noradrenaline, and the patient was currently being run on double-strength adrenaline. And I had another piece of good news. Terry Sadowski, paramedic extraordinaire, was going to be accompanying me in the multipurpose vehicle. Now, the logistics of this case, I think, are well worth noting, particularly when it comes to a retrieval case. While I was just one cog in the treatment of this patient, there was actually many moving parts to treating this patient and retrieving them to a tertiary center. Firstly, Leeton is a nurse-only clinic that is about 6 hours drive from Sydney. Because this patient is 280 kilos, he could only be moved by a multipurpose vehicle, and the heavy type. There's only 2 heavy multipurpose vehicles in New South Wales. So the step 1 was to locate a heavy vehicle, and then step 2 was to locate an MPV qualified paramedic who needed to then drive to Leeton. And there's not that many MPV qualified paramedics, which is something that we'll go into a little bit later. Now, step 3 was to locate a second MPV qualified paramedic and fly them to Leeton and then drive the MPV from Leeton to Canberra. For fatigue reasons, once the first paramedic arrived in Leeton, they would be unable to continue the journey on to Canberra. There was also the fact that a medical team needed to be sent immediately for emergent resuscitation of this patient, and then a second medical team needed to be sent to relieve that medical team, which had by then gone into overtime from their day shift, and we were to retrieve this patient from Leeton to Canberra. So essentially, and finally, we would be required to drive the MPV, the paramedics, and the medical team back from Canberra to Sydney. This, in total, started at the beginning of my shift, and my shift ended 15 hours later, and I wasn't even involved in the resuscitation of this patient. Now, I did get some inside footage into the coordination of this patient's retrieval into ACC, and I'm not able to tell you where I obtained this video, but I think it went a little bit like this. Now, for the purpose of aeromedical transfer, we need to talk a little bit about which patients can go in which modality. We define bariatric patients as 110 kilograms or more, and that is a New South Wales specific standard operating procedure. I'm not sure how relevant this is to other states. Now, for our road vehicles, they carry a standard striker stretcher, which is rated to 318 kilograms and 67 centimeters wide. However, the maximum patient weight for these vehicles is 175 kilograms. Our fixed wings are rated to 240 kilograms, but they require special vehicles and stretchers for the tarmac stretcher transfers. Essentially, going from the fixed wing and the airport to the tertiary or relevant center is going to require a heavy vehicle as well. The helicopter has a PLD with a max load of 340 kilograms, an SPS with a max load of 340 kilograms, which gives us a maximum patient weight of 260 kilograms with the width determined by the cabin once you add on all your other bits and pieces. And helicopters carrying bariatric patients will need to land on a dedicated concrete pad. If your patient is over 260 kilograms, your only option is to travel by road. Now, in terms of what our capacity is in New South Wales, we have a couple vehicles floating around, and essentially there's a distinction between your MPV lights and your MPV heavies. Now, your MPV lights are essentially exactly like an ambulance, but just a little bit bulked up. They're a little bit wider, they're a little bit longer, they're rated to 380 kilograms, but that doesn't include the bridge or the equipment, and you can only access the patient from one side. The main limitation for these vehicles is actually width. Often you find that patients' width exceeds the configuration that we're able to fit in the MPV lights. There's 2 MPV heavies in Sydney. They're located at Liverpool and St. Ives, and they service the entire state. It is a custom-built truck, which has a power lift 600 stretchers, rated rather obviously to 600 kilograms. There's bilateral patient access. They're a bit of a one-of-a-kind truck. They were a prototype, and unfortunately, they're quite often unserviceable for various reasons. Now, there's actually flowcharts for people who task and coordinate the transfer of these patients to follow, and it has to do with adequate sizing and weighing of these patients, and it also has to do with your options between different patient sizes and widths, taking into consideration the tarmac, the concrete helipads, the vehicles for the tarmac transfers, etc. Quite often logistically, although there's often a shortage of trucks and drivers, it is easier to transport these patients by road. And I just wanted to put up a picture of our MPV, the double-sided truck, compared to a standard road ambulance, just to give an idea of the additional access and width that gets afforded in these trucks. Now, in terms of the paramedic side of things, they do need to complete an MPV operator course to be able to drive and operate the MPV. And there's generally anywhere between 1 to 2 on shift in the entire state, and sometimes there's none. There's not that many paramedics that are actually fully trained in operating an MPV. There's several issues with the truck breakdowns, as I mentioned earlier. And the biggest challenge, it's a little bit like herding cats, it's locating both the vehicle and making the vehicle come to the area that you need it, and then the operator and making the operator come to the vehicle and the patient. These paramedics, although they are MPV operators, they're still working their regular day jobs and they're rostered onto normal ambulances, so we need to wait for them to become available for a job as well. The MPVs need to be configured with all of our equipment, so for patients being transported by us, we need to think ahead in terms of what equipment we'll need to take, i.e. your primary packs, your interhospital packs, your ventilator, your monitoring, extra pumps, etc. Now finally, I think manual handling is really important to mention in these patients. The MPVs do come equipped with manual handling gear, and your paramedics will be certified to manually handle this patient. They will come with a bariatric carry sheet, a hover pump and jack, and a hover mat. And these hover mats are essentially, I'm sure you've all used them in your regular work settings, but once inflated, they allow a patient to slide across the bed. You need a minimum of 6 people to utilize a hover mat and organize transfer. So let's go back to the case a little bit, keep things fresh. And so on the arrival of the initial medical team, the patient was being pre-oxygenated with BiPAP, and then they were intubated with video laryngoscopy. They had a CMAC blade 4 with a size 8 tube inserted, and it was a great view after their excellent efforts at positioning this patient. It was a difficult ventilation secondary to the body habitus and the bilateral pneumonia. Despite being ramped up to 30 degrees, it was quite difficult to maintain SATs over 95% on FiO2 of 100. He was exquisitely inotrope dependent. So on arrival of our medical team, this patient was on an adrenaline infusion, which was being transfused by the CBC. He was double pumped and eventually transferred onto the MPV on noradrenaline. And we actually added vasopressin to that because in obese patients it's quite useful to add a Splanchnik vasoconstrictor. Generally in shocked patients it can be quite useful to add a Splanchnik vasoconstrictor, as this allows you to sort of spread the vasoconstriction a little bit and prevent some of the worst side effects that arise with adrenaline and noradrenaline. Unfortunately, this patient, despite having excellent venous access, had failed art line insertions despite being attempted by very experienced clinicians twice. But he was his blood pressure was being monitored 2-minutely via NIBP, and we were happy with that. He'd had a total of 7 liters of crystalloid infused by the time we arrived, and he was basically oliguric despite this. His sedation, so he was a GCS3. He hadn't been paralyzed for over 3 hours with absolutely no spontaneous breathing, coughing, no responsiveness on the tube. He was just being maintained on low doses of fentanyl and midazolam, both running at 5. He remained febrile despite having received antibiotics and antipyretics. He had an IDC in situ. His BSLs were downtrending, pretty much the only physiological parameter that was improving in this patient, from 38 to 32, and his ketones had decreased from 4 to 0.8. He had an ACT rapid infusion running at 15, and he remained very hypernatremic, and that was uncorrected. So for the purpose of our transfer, he remained intubated. We were unable to wean the FiO2s and maintain SATs of over 95%. I maintained him on ASV mode on the Hamilton and noted slightly increasing airway pressures for the duration of the transfer, which, as I mentioned, took several hours. On arrival to Canberra, he had a chest X-ray, which basically showed a bilateral whiteout, which was much worse than when we had left Leeton. He had slowly increasing noradrenaline and vasopressin requirements en route, which we titrated to a MAP of over 65. His GCS remained 3 for the duration and didn't require reparalysis at all, and was maintained on very minimal sedation. The ACT rapid infusion continued en route, and he remained oliguric. Now, unfortunately, this particular patient didn't have a good outcome, but I think there was a lot to learn from this case. I'll just leave you with some final tips and tricks. My first tip is to be second on scene and to arm yourself with an array of just excellent paramedics and doctors and nurses by your side. It was incredibly helpful to be able to share the mental load and share some of the tasks in managing this patient. I think application of a Sadowski level of attention to detail in your packaging and transfer consideration is generally good retrieval advice, more so in these patients due to the aforementioned difficulty in vascular access. And you can really get tripped up with a lot of minor things, such as increasing airway pressure because of kinking tubes, etc. I think it's just really important to be slow and systematic insofar as it's possible, to make sure you don't get tripped up by that. I think it's important, even before you attend to these patients, to start with a proper information. How and when was this patient weighed, and who has done the sizing of this patient? This is more in the role of the SRC and ACC, but they'll be definitely sending those charts and making sure that the local teams will get an accurate description of the patient's weight and width for us. I think with these patients, positioning prior to intubation and post-intubation is very important. Like I mentioned, as much ventilation of West's lung zone 3 as possible will be very helpful, and the ventilation tends to be the biggest issue often with these patients, so a little bit will get you a long way with aiding that ventilation. Sitting them up will move some of that weight off of their thoracic wall, and it'll also just help with your shunting and ventilation generally. I think it's important to go big or go home, so don't be afraid to intubate these patients. If that's the way that you're headed, start early with adequate pre-oxygenation and positioning. Start early with central access and your invasive blood pressures, and make sure that everything is secured to a Sadowski level. And finally, for me, a big tip was the addition of a Splanchnik vasoconstrictor, which was not within the realm of my regular practice prior to this case, but has certainly been added to my arsenal since then. We don't actually carry any vasopressin, but ACC in this particular case was excellent at facilitating a delivery from Liverpool Hospital prior to our departure. And that's it for this case. Thank you so much for listening.